Assalamu alaikum. I welcome you all in this lecture. Today we are going to discuss about the studies based on routine data and how we are going to analyze those data. So by definition it means that the data about exposure and outcome both are collected from routine data collection system, and these systems may include cancer registries, hospital registries, or the record keeping systems like in our case that's NADRA over here in Pakistan. So these routine data records can also provide us a useful information, and they are a valued asset for further studies. So let us decipher few things. Now the first foremost format would be at individual level. The information which is provided could give us a detail about what type of disease is more prevalent in any population or in any specific area. For example, what you are looking right now is the demographic location of Central Asia. There are certain countries mentioned over here. That's Kazakhstan, and then we have seen China, India, Pakistan, Afghanistan. The prime interest is if we focus more towards the northern borders, we say that the prevalence of a particular type of cancer, which is esophageal cancer, are much more high in poor areas, and these areas dietary habits are being studied. So that the study was not conducted in an intentional purpose, but these were the journal observations which were recorded on cancer registries that the people residing in northern areas and this dark color area are more affected from, in this portion of Iran as well, this region. These regions are more pronouncedly affected with esophageal cancer. When they are compared with the dietary habits, they came to know that this area contains what you can say uh, limited intake of protein source. So this is like an individual effort made. Now, what you are looking right now is the place of birth and ethnicity, and this study was conducted to assess that whether the immigrants coming in Australia from different European countries, are there any chance of risk of their death dying from melanoma, skin cancer, is more or is the same as in Australian? So let's assume that the relative risk of um, people dying from skin cancer is 1 in Australian origin individuals. What about English, Irish, and the rest of the European countries? So the observation is made that the European immigrants were at lower risk of dying from melanoma than Australian born individuals, particularly in Southern Europe. Now, based on this approach, it has been noticed that the English people are having what you can say an inborn ability to save themselves from skin cancer in Australian environment. So environmental factors and a genetic background is a contributory study. So such kind of studies which are based on routine data sets are providing us a useful information. Similarly, sometimes the information retrieved from first or second generations could also provide us a useful intake. For example, what you are looking is stomach, liver, colon, and prostate cancer. Now, in the Japanese population, in Japan, the most highest prevalence of cancer is stomach cancer, followed by liver cancer. While in these two cancers, now stomach and liver cancer incidence are high in Japanese. But when these Japanese individuals, their first or second generation, settled in California, the prevalence of this cancer is marginally reduced. As you can see, the bars for first and second generation are further reducing as compared to the white people who are already residing in California. So these are the study record based informations we are driving from Japanese individuals' immigration status. But on contrary to this, if we look at the Californian population, the population is suffering from colon and prostate cancer. So the while in Japan, both colon and prostate incidences are much less. Now, the first generation and second generation individuals who have migrated from Japan and settle in California have an increased risk of these cancers, colon and prostate. Look at the bars. Look at the bars. The bars are gradually higher in this proportion. So the incidence of colon and prostate cancer are rising as compared to the native land where there is much low incidence of colon and prostate cancer. This means that the environmental factors or dietary factors do contribute towards the initiation or prevalence of a particular form of cancer in any different area. Next, socioeconomic status and occupation. In this study, it was studied that whether the lifestyle or outdoor exposure affects any particular form of cancer. The observations were recorded, and these observations stated that the farmers and farm managers have, like what you can say, observed 23 cases. The higher incidence was observed in farmers and farm managers when compared, and then agriculture workers are the incidence is substantially high. So both agriculture and farming are increasing the exposure of a particular form of cancer. This means that the socioeconomic status or occupation does influence the person individual lifestyle. So the outdoor individuals are more prone to any particular form of cancer. That's how we came to know any other details about this cancer. So this is just a general observation. For example, that workers who are working in tanneries are more exposed to the leukemia cancer. The individuals who are working in certain wards or what you can say in weapon industry are more prone to leukemia because of the sulfur availability and different chemicals which are really harmful for their body. Now, the mortality rate of, and this also helps the same in continuation, the socioeconomic status also helps us to understand certain prevailing phenomena. For example, if we divide the social class system into 1, 2, 3, and 4, 5 status, we noticed a very interesting pattern that the mortality rate of women suffering from cancer is mentioned over here. So these are the women who have suffered from cervical cancer. Their mortality standard mortality ratio is being described over here. Okay, and over here their husband occupation is being listed. So if we look closely, we could see that the mortality ratio of fishermen, deck engine room ratings, similarly laborers, the persons who are living in what you can say towards the lower border of the socioeconomic status, their women were mostly suffering from cervical cancer. Now this pattern, I have to correct this mistake, cervical cancer spelling mistake, I know, but this indicates a very interesting thing that the people who are living, who are working outdoors, are away from their homes, their women are dying from cervical cancer because of sexually transmitted disease infections. While the people who are living in far-flung areas, they are free from such kind of infections or disturbances. So the people who are living or having a professional background or career from upper social circle like scientists, civil engineers, teachers, they are free from these disorders. So this is an interesting thing we need to know and decipher in details. Okay. Now the next pattern is about the this testicular carcinoma data. What we are noticing over here, there are 6 countries. The data has been shown over here, and this data indicates that the incidence of testicular carcinoma is low in Denmark, Norway, and Sweden when compared with the rest, East Germany, Finland, and Poland. So the ecosystem do also play an important role. However, we are unable to understand why the incidence of a particular form of cancer varies between two regions, like the incidence of any cancer varying between Punjab and KPK or Balochistan. So, or something what you can notice, the incidence of COVID-19 prevalence is different in different regions of a province even. Okay, so this is something what we learn from the old cancer registry records or the prevailing hospital databases. This is how we understand different phenomena. For example, in this case, the isolation of the role of sexually transmitted disease was established quite later, but the data what you are looking right now is generated in 1970s. So this data provide a uniform information that the people from low socioeconomic class usually travel far from their homes, and they have relationships or intercourse in distant places, so they are responsible for carrying a disease to their uh, counterparts in the other house. So this should be restricted. Later on, we came to know that there are certain viruses or bacteria which are responsible for this STD infections. Similarly, the time trends in thyroid cancer, if we can see that there is an assessment that the treatment of esophageal cancer was done in 1940s with an aggressive form of radiation exposures, and radiation exposures were aggressively given to the individuals for the treatment of certain type of cancers. But in that era, it came to know that the earlier treatment of radiation exposure may expose them to a secondary type form of cancer. Okay, so an individual who was treated at the age of 5 years or 14 years for any particular form of cancer and given a radiation therapy, later in their lifespan at 35 to 44 years of age is showing higher incidence of thyroid cancer. Okay, this is the graph which we are noticing, and the data we have collected is from 44 years, 1944 to 1975. So the number of individuals enrolled in this study were at 5 years of age in 1954, and then they were followed till 1975 with the mean age of like 85 years of age. And we see that the exposure of radiation increases the likelihood of thyroid cancer. So basically we were curing the patients at one time point, but the harmful effects of that medicine reoccur at any distant point in life. This is how we assess the safety margins for a drug as well. So, how early screening has an impact on cancer reduction? If you look at this graph, this is an interesting story that why Pakistan should also adopt an early screening program for breast cancer, esophageal cancer, and other form of cancers. Is if you look at the Denmark population, the pattern of rate per 100,000 persons per year, the cancer of cervical cancer remains almost the same between the border of 25 to 30. This is because from 1945 to 1975, the system of health screening was not established in Denmark. So the Danish women were suffering from the cervical cancer based on poor early screening. But if you look at the pattern of Swedish and Finnish women, you can see that an early screening saved many lives. From an early effective screening, the incidence was already low in both Swedish and Finnish population, similarly Iceland population, because their effective early screening reduced the number of women suffering or dying from cervical cancer. Okay, this is how a simple cancer registry record is helpful to implant any other policy measures. Okay, whether we should adopt this method or not. Now, how could we show a record linkage studies? This the earlier former example was also the same course, and a cohort of let's say 74,000 men in Denmark was identified retrospectively from hospitals and pathology registries that have done vasectomy. Okay, and this vasectomy was performed in like from last decade. They were passively followed from the time of their operation to 1988, right? And then the occurrence of cancer among cohort members was ascertained by linkage with National Cancer Registry, that how many of the male individuals who have done vasectomy, vasectomy is sort of castration, who have performed castration in 1977 to 89, how many of them suffered from testicular carcinoma, and the record was retrieved from National Cancer Registries. So roughly around 74,000 individuals were followed. So this kind of study is called record linkage study. Okay, record linkage study was like, if we want to know how many of the individuals who have been vaccinated today remain fertile, okay, and for let's say from 21 to 2023. So this is a record linkage study, and we observe these individuals from 74,000 individuals. So such kind of studies are called record linkage studies. By the way, COVID vaccine doesn't have any influence on the fertility or the sperm motility ratios as well. Okay, so this is all what we need to say. Now this is an excellent example. Is in this example we say that suppose we want to know the proportional incidence ratio. For proportional incidence ratio, how we proceed? We say that in the population of 10,000 individuals, let's suppose that 2,000 individuals die from lung cancer, and the expected value was zero point 0.2. Okay, now suppose there is a certain profession and the people are involved in that profession. Now in that profession, let's say there are 100 individuals who are engaged in a certain research area, and out of them 40 individuals died. So the observed proportion of individuals would be calculated, and for observed proportion we do simple mathematics over here, and we calculate proportional incidence ratio. This is how we conduct a record based study, and we say that, look, based on this occupation, the risk of lung cancer is 2 times more than the general population. That's important. So the proportional risk in incidence can be calculated this way. Thank you very much for your time and valuable attention.